Welcome to Entertainment Plus. I'm Jan Waldman, and today we're at the North Shore Medical Center with Dr. Howard Waldman, the Medical Director of the Cardiac Catheterization Lab and Director of Interventional Cardiology, and newly appointed Chief of Cardiology. Welcome, Howard.
Thank you.
Thank you for agreeing to do the interview today. I think there's a lot going on in Salem, and I think it would be great for the community to be updated on everything that's new and what's happening.
It's my pleasure.
So maybe you can start with your education.
I will start with my cardiac education. It began many years ago in research at Georgetown University. I received my Ph.D. in cardiovascular physiology and biophysics, studying various aspects of platelets and vessel wall interaction, and was doing my postdoc research when it occurred to me that I was dealing more with test tubes than people. Mm-hmm. And I decided it would probably be more fun for me to include people. And as a result, I went to medical school where there were plenty of people.
And where did you go to medical school?
I went to medical school at State University of New York at Buffalo. Mm-hmm. And after graduation, I did my internship and residency at Chapel Hill, University of North Carolina, Chapel Hill.
Mm-hmm. And is that where your interest in cardiology started?
Oh, my interest in cardiology began back in the research days in the cardiovascular unit at Georgetown. I was always focused on cardiovascular physiology. That's what interested me most.
Did you know you were going to be a cardiologist when you were at Chapel Hill?
Yes.
Okay.
I was already focused on cardiology in some aspect, though I wasn't sure if I was going to become a cardiac surgeon or a cardiologist.
Okay, and you chose a cardiologist.
Indeed. So from Chapel Hill, I was accepted at Mass General in the cardiac fellowship program, and that's where I was trained to be a cardiologist. And following my residency and fellowship, I was appointed on staff at Mass General, where I have been for the past 32 years.
Oh, that's great. Now, when did you decide to become an interventional cardiologist? Maybe you could tell us the difference between an interventional cardiologist and a regular cardiologist.
During cardiac training at Mass General, you are exposed to all disciplines in cardiology, and I was intrigued by the cath lab and the things that occurred in the cath lab and the ability to intervene and actually have an impact on patient outcomes with interventional cardiology. So I should take a moment and explain interventional cardiology includes coronary angiography, taking pictures of the arteries that feed the heart, looking for narrowings or blockages in the arteries that feed the heart, and then if we find them and if it's appropriate, we can intervene, which means open those arteries, put a stent in, and restore blood flow to the heart muscle downstream. Of the three arteries, the right coronary artery has its own origin, and this is a right coronary artery, which is smooth and normal, wrapping around the heart. The left coronary artery comes off a main trunk called the left main and then separates into the other two branches. And each of the main arteries has multiple small branches which feed the heart. So here's the left main artery, the left main coronary artery, and it separates into the LAD and circumflex vessels. Now we take several different views of the heart, and the reason is that if this is the only picture you ever see of my finger, you never know there's a nail on the other side unless we look at the other side. So in the cath lab, we rotate the camera around the heart so we can see all sides of the vessel. Left main, LAD, circumflex, and in this view, left main, circumflex, LAD. Interventional cardiology also includes many other interventions, such as valve repair and closure of defects in the heart, such as an ASD, which is a hole between the upper chambers of the heart, or a VSD, or a patent ductus. There are many interventions that we can accomplish in the cath lab.
It's pretty amazing. What you can get done without going under the knife.
So years ago, most, in fact all, angiography in the era that I was trained was performed through the groin, through the femoral artery. And in the past several years, we've transitioned from the groin to the wrist. And now we can actually fix someone's heart through a little IV in the wrist. And it's quite amazing, and patients are astonished, and they're quite appreciative of the fact that they are basically unrestricted after an intervention. In the old days, they had to sit with a 5-pound sandbag on their groin, and some of the older viewers who have had a catheterization may remember having to sit for hours with a sandbag on their groin. No longer the case. We put a little pressure band, like a wristwatch, on the wrist, and they can move and eat and sit up, and it's really changed how we perform our procedures and the convenience for the patient and the safety of the patient.
We'll get back to this, but I'd like to touch on the history of cardiology as you know it here at Salem Hospital.
The history of cardiology dates back in my recollection to Max Kaulbach and Larry Finkelstein. Max Kaulbach was trained at Mass General and came up to the North Shore and began practicing cardiology here. And he was responsible for opening the cath lab, not this particular room, but he was the one who opened the first cardiac cath lab on the North Shore. He also was the first cardiologist to bring several technologies and techniques to the North Shore, including the intra-aortic balloon pump, which is a device which supports the heart during a heart attack or if someone's in cardiogenic shock, other situations, and it was basically a life-saving device that he brought the technology to the North Shore. And here is an example of an intra-aortic balloon pump which we use to enhance blood flow down the coronary arteries in patients with cardiogenic shock or issues with diminished flow. This is a balloon pump. It's in the descending aorta, and you can see the balloon opening and closing, and it's timed to the EKG so that it inflates during time of diastole when the coronary arteries fill, and it enhances blood flow down the coronary arteries, and closes when the heart squeezes to let blood out to the body. So this long sausage is an intra-aortic balloon pump beating in time with the heart to enhance blood flow down the coronary arteries and support the function of the heart.
That's impressive. I
Indeed.
like that. It really is. And so, when did you come into this mix?
So Max had several partners over the years, including John Santos and Chester Clark, and people come and go and age and retire. And I joined the practice in 1991, along with my partner all these years, Dr. Mark Anderson. And at that time, it was Max and Chester Clark, Max Kaulbach, Chester Clark, Mark Anderson, and myself were the core group of North Shore Cardiology. Chester Clark moved to Washington, and he was replaced by Dr. Andrew Kemper. Max retired and was replaced by our current president of North Shore Cardiology, Dr. David Rabin. Over the years, we were aligned more and more with Mass General Hospital, where I'm from, trained, and I, as I mentioned, still work there. And there were two competing cardiology groups on the North Shore. We decided that we would merge to coalesce cardiac services for all patients, and in doing so, we were also able to align very closely with Mass General to have essentially one seamless cardiac product line where if you came to North Shore Medical Center and needed cardiac attention, all of the services were here except for intervention in the early years. If you needed intervention, you would be sent to Mass General, where either I or my partner, Dave Roberts, would meet the patient and perform the intervention. If they needed
At Mass General.
At Mass General. If they needed cardiac surgery, bypass surgery, valve surgery, that would be accomplished at Mass General. And if someone has a heart attack on the North Shore, the most important aspect is time. And if they come directly to the hospital, we take care of their heart attack in an extremely efficient and timely fashion without the need of being shipped into town. And that program has been up and running since 2003 and continues.
Now, when did you build the new cath labs?
Well, there's been a series of cath labs, and we moved into this lab, maybe 8 years ago, and we've upgraded the cath labs. In this particular suite, there are two labs. This room, which you see, which is the primary coronary or intervention room, and we have a room across the hall, which is the primary room for electrophysiology. We have full electrophysiology services. Dr. Michael Ketcher, the director of electrophysiology and pacing, and Dr. Nate Van Housen, his partner in EP, perform a full range of electrophysiology procedures from simple pacemaker implantation to internal cardiac defibrillators to atrial fibrillation ablation and a flutter ablation that's correcting abnormal heart rhythms right here in the cath lab.
Now, what exactly what are the procedures, some of the procedures you do? Maybe you can describe a couple of them.
As an interventionalist, I am an angiographer, which means I take pictures of the coronary arteries that feed the heart and look for narrowings or blockages that obstruct blood flow to the heart muscle. So in simple terms, here's the heart beating. And there are three main arteries that wrap around the heart and feed it. If there's a narrowing or blockage in one of those vessels, the heart muscle downstream doesn't get fed.
Right. And that's not good.
No, if it's a sudden event, if you suddenly stop the blood flow to the heart muscle downstream, that's what precipitates a heart attack. The heart muscle begins to starve, and if it continues, it starves to death, and that's the definition of a heart attack. Loss of heart muscle because of lack of blood flow and lack of oxygen. Not all narrowings cause heart attacks. Narrowing can cause angina, which is defined as any symptom somebody has as a result of not enough blood flow to the heart muscle. And sometimes it's determined by a stress test or symptoms which lead to a stress test, and we find that there is an area that's not getting enough blood flow. The patient then comes to the cath lab. We take a picture. We define their coronary anatomy. And if there's a narrowing or blockage that's suitable for angioplasty, we proceed with that. Angioplasty is the procedure where we open a vessel with a balloon initially, take the balloon out, and then put a stent in, which is a metal mesh tube that goes in and keeps the artery open. This is an example of a stent.
Is that what goes in there?
Yes.
It looks very solid. I would think of it as something more flexible.
It's very flexible.
Is it?
It's a little metal mesh tube, cobalt chromium, and
Okay.
the stents we use today, most of them are coated with a drug, and we call them the drug-coated stents. And the medication that's on the stent is eluted into the vessel wall just in the local area, which prevents ingrowth of atherosclerotic material. It keeps the vessel open. It prevents restenosis.
Now, do people have to have it redone, or you just never know?
There are instances where there is slow regrowth of the atherosclerotic plaque, and it plugs the stent, and we can reopen them. There are some more urgent situations where, because of failure of medication or noncompliance with medication, where the stent can suddenly occlude with a clot, thrombus, or platelets.
And you have to go in again.
And we can go in and clean them out and re-expand, or even put another stent in if need be. Once a stent goes in, it stays forever.
And what's the recovery time for this? You come in the night before, the morning of?
It depends if it's a heart attack or if it's an elective case.
Okay.
Or a non-emergent case. But in general, it's basically a day.
Oh,
if it's a
that's
heart
nice.
attack, it's longer because we have to let the heart recover from the insult and get the patient on a series of medications to protect the heart and so on. Depends how severe the heart attack was and how much babysitting we need to do of the patient.
Yes.
But if you're coming in for an elective case and we go through the wrist and we take a picture of the heart and we put a stent in, if it's first case in the morning and there are no issues, you can go home the same day.
That's nice.
And if it's later in the day because of safety issues or if there are any concerns at all, it's an overnight stay and home the next day. So the recovery is very short.
And this gives good results, correct?
Excellent results.
Yes.
As I tell patients, they come in, they have angina, they have a positive stress test. They come in and get a catheterization, and we see a blockage, and we open it and put a stent in. And then they worry. And I tell them, well, actually, your heart's now fixed. You can go home less worried. Now you just need to take care of yourself, take care of your heart, take care of your cholesterol, take care of your stent, etc. But you're going to leave here better than when you came in.
That's nice.
One concept about the stent is wherever we put a stent, they stay forever. It becomes part of your vessel.
Okay.
We don't go in and take them out and replace them. It's not 20,000-mile change. Wherever we put a stent, it stays forever. It becomes part of your vessel. We can add stents, but whatever goes in stays forever. And with the stent, you can do whatever you like. You can have an MRI, you can have a CT scan, you can go to the airport.
CT, oh, that's good.
You can use a microwave, you can use an electric toothbrush. They don't do anything
That's good.
other than keep your artery open.
Now, what other procedures do you do in the cath lab?
In addition to your standard coronary angiography and angioplasty and stent placement, we evaluate different cardiac lesions, such as if someone has a valve problem. So I mentioned that there's the pump and the arteries that feed the pump. Inside the heart are valves that open and close and let blood in and out of the pumping chambers. Then these valves can misbehave. They can narrow, and that's called stenosis. And a very common lesion is aortic stenosis. The main valve leaving the heart gets narrow. Instead of opening widely, it opens very narrowly, and it impacts the ability of blood to leave the heart, which can cause a whole host of problems. We evaluate valvular heart disease. It doesn't matter which valve. We can evaluate all of the valves that live in the heart. And sometimes surgery is necessary to repair that. Other times it can be addressed with the newer procedure called TAVR, which is the transaortic valve replacement procedure, which is done through the groin. We actually install a new heart valve non-surgically through the groin. And there's a hybrid procedure where it's partly through the groin and a small incision in the chest, and it's still less invasive than a full standard valve replacement. Those procedures are done with our cardiac surgeons at Mass General and our cardiac interventionists at Mass General.
Well, it sounds like you have a good team. What other things do you offer, or what other programs do we have here?
As mentioned, we have a full range of cardiac programs, from, as I like to call it, prehab to rehab. We have programs to help keep people healthy and prevent heart disease, nutrition and exercise and meditation and so on. Our diagnostic programs span everything from heart failure to, as I mentioned, electrophysiology. We have a very robust heart failure program run by Dr. David Rabin. And heart failure is, as we age, a more and more common malady, and managing people with heart failure can be a challenge, and we have a very robust program for heart failure management. Sometimes heart failure requires what we call resynchronization therapy, which involves our electrophysiologist. If the heart is not functioning normally, it can sometimes be dysynchronous. And with special pacing wires, we can resynchronize the chambers of the heart so that they function more efficiently together, which improves heart failure. So everything from standard medical therapy to newer medical therapies, all the way up to and including resynchronization therapy with our electrophysiologists. In addition to heart failure, we have a full range of diagnostic testing, stress testing. There's different types of stress tests. There's the standard walking stress test. There's the pharmacologic stress test that goes a step further than just the electrocardiogram showing where blood flow goes in the heart. There are echo stress tests, and we do a full range of echocardiography, the ultrasound of the heart. Now, ultrasound of the heart is an excellent test which actually shows the structure and function. It shows the heart, all the chambers beating. It shows the valves opening and closing. It can show if there's any fluid around the heart. Stress testing, echocardiography, heart failure, angiography, electrophysiology, and of course cardiac rehab. So if you've had a heart attack, if you've had a coronary intervention such as angioplasty, if you've had heart surgery, it behooves the patient to participate in cardiac rehab. Studies have shown that people who have had a cardiac issue that participate in cardiac rehab do better. They have less events and less readmissions to the hospital and better quality of life. So we have a very excellent and robust rehab program as well. This is an echocardiogram, an ultrasound of the heart, and again we do different views to look at the heart in different perspectives. This is called the four-chamber view, and the way the echo works is it's actually upside down. So up here are the two, believe it or not, upper chambers of the heart. These are called the atria. This is the left atrium, which gets blood back from the lung. That goes down through the mitral valve into the left ventricle, the pumping chamber that goes out to the body. After blood circulates through the body, it comes back to the right atrium, the right-sided collection chamber, through the tricuspid valve into the right ventricle, which pumps it out to the lung to get fresh oxygen, and then it comes back to the left side, out to the body, back to the lung. So the two atria, the two AV valves, these are the valves that live between the atrium and the ventricle. On the left side, the mitral valve, letting blood into the left ventricle. On the right side, the tricuspid valve, letting blood into the right ventricle. This is a different view of the heart, slicing through the heart longitudinally. Here's the left atrium, the mitral valve, letting blood down into the left ventricle. And in this view, the right ventricle is on top. Here's the sternum, the right ventricle, and the left ventricle is behind the right ventricle. And this is a normal functioning heart. The wall thickness is normal and the squeeze is normal. And back to a modified 4-chamber view. This is actually called a 5-chamber view because we see the left atrium, mitral valve, left ventricle, and the aortic valve. This is the valve that lets blood out of the left ventricle to the body, right atrium and right ventricle. And these views allow us to look at the size and function of the heart and look at the function of the valves, whether or not the valves open and close properly, and what the flow is through the valves. This is an example of Doppler flow, and this shows that there is no problem with blood flow through the mitral valve. This view, the modified 5-chamber view, shows blood flow through the aortic valve. This is blood leaving the heart through the aortic valve out to the body. And this is normal appearing flow.
Can you tell us about symptoms of a heart attack? I know that they're different for a male and a female.
Symptoms of a heart attack can be typical or atypical. The first thing I want to point out is that people use the word pain. Do you have any chest pain? Most patients will say, well, I never had pain. When a doctor says, are you having pain, he's referring usually to aching, squeezing, burning, heaviness, tightness, sharp, dull. But pain is a quick word to cover all of those qualities. Angina is typically not what people refer to as chest pain. It's more of a pressure sensation or a squeezing or a terribly uncomfortable feeling.
And what do most people say? An elephant sitting on your chest?
A very common expression is, it felt like an elephant was sitting on my chest. Though I've never actually met anyone who had an elephant sit on them. But it's an interesting phenomenon that's their interpretation. That's what it feels like. That's what the heaviness sensation. In a situation of a heart attack, some patients feel a sense of doom. They say, I felt like something bad was going to happen, a sense of doom.
A premonition almost.
Yes. Anyway, the concept is it doesn't have to be a sharp pain. It's usually not. It's usually a pressure or a squeezing. And that can be in any location. It could be mid-chest, it could be in the throat, pain radiating up to the throat, to the back of the neck, between the shoulder blades. Women have more vague. Less often will they have the classic squeezing. There's something called Levine sign from Dr. Levine, a cardiologist from downtown. Patients describe this sensation, and they make this motion with their fist, the squeezing sensation. That's called Levine sign when they make that balled up fist in the middle of their chest. What's more common in women is less focused, a vague sensation in their neck, in their jaw. They just don't feel right. They're uncomfortable.
Indigestion?
Indigestion can always be a symptom of either indigestion or angina. Sometimes you can't tell the difference because certain GI problems, esophageal spasm, can exactly mimic a heart attack. The issue is if you're having these symptoms, get prompt medical attention. Let us make the call. Because if it is a heart attack, the sooner you show up, the sooner we can get you to the cath lab and open that artery that's causing the problem. In any case, women often brush it off saying, I have too much to do, this can't be anything. The key is if it persists. Now, patients sometimes have little sharp stabbing pains that come and go within a second, a little pinprick. That's typically not angina. Angina tends
So
to...
not a heart issue.
Correct, a musculoskeletal. Angina, if it's happening, tends to come on you and stay with you for more than one little second of a pinprick. And it's an uncomfortable sensation. And one way I describe it to people is if you have a discomfort and you stop and think about it, what is it? Have I ever had this before? One question to ask yourself is, have you had it before? And another is, does this feel wrong? Sometimes patients say, this just didn't feel right. Something was wrong. If you get that sensation or that notion, seek medical attention. Let us make the call. If it's nothing, home you go. If it's something, you're so far ahead of the game by having it taken care of promptly.
And people should err on the side of caution.
Absolutely.
Yes, you always say that.
Going home is easy. The reason to call an ambulance if you know you're having angina and it's getting worse, or if you think you're having a heart attack and you're feeling awful, etc., don't ask your spouse or your friend to drive you. The reason is that an ambulance is basically an emergency room on wheels, and there is somebody there not driving who can attend to you. IV medications, more than 80% of medications in an ambulance are cardiac meds. If your heart goes into an abnormal rhythm because of a heart attack,
They have the medication.
both the medication and they have the devices, the defibrillators that can put you back in a life-saving rhythm. Here's an example of someone having a heart attack, and this vessel right here is totally blocked, right there. It should be coming out and wrapping around the heart. So we identified the vessel, which is in a different view. Right here it should be coming down like this, and there's no blood flow in this vessel. We're now going to advance a wire through the blockage into the vessel. This is where the vessel should be. In fact, this wire is inside the vessel, but there's still no flow. We put a balloon in across the blockage, inflate the balloon, which you can see here, it's inflated, and that results in some blood flow. Now this is a very diseased vessel. There's a little bit of flow, and through the magic of video, fast forward to we're putting a stent in. This is a stent in the blocked artery. We're going to inflate the stent, and that results in blood flow returning to the heart muscle. So once there was no flow in this vessel, and now there's flow into a very narrow vessel because it's diseased and its branches. So blockage, stent, restoration of blood flow to the heart muscle.
I would like to talk about snow shoveling. I think that's important. Can you shed some light on that?
Yes, I have nothing against shoveling snow per se, other than you have to use your head. How old are you? Do you have a cardiac condition? What's your blood pressure? Are you on medications, etc.? You need to be smart. And I tell a lot of my patients that are in their 70s and 80s that they've earned the right to hire somebody to shovel the driveway.
Exactly. Dr. Waldman, there are some big changes at North Shore Medical Center in the cardiac department, and you are losing a partner, but he's going on to bigger and better things. Can you tell us about that?
Yes, Dr. David Roberts, my partner for the past 15 plus years in the cath lab and in our interventional service, was appointed president of North Shore Medical Center by the Partners Board. As a result, I have been promoted to chief of cardiology at North Shore Medical Center.
That's wonderful. That's a big deal too.
Indeed. I'd just like to emphasize that I think the North Shore Medical Center is in outstanding hands with a physician at the helm, someone of Dr. Roberts' caliber, intelligence, integrity running the hospital is a great benefit to the hospital. And I'd also like to emphasize the cardiac division at North Shore Medical Center is alive and well and providing a full range of services as we've outlined in our discussion this evening.
Yes, that's what we wanted to do today, was to share with the community what is here, what is strong, and what continues on. So thank you, Dr. Waldman, for your time and for sharing all this with the community. And thank you from Entertainment Plus. And find us on Facebook.